Dr. Sabanayagam Vaidiyanathan is an anesthesiologist and has an experience of 21 years in this field. He completed his MBBS from the Tamil Nadu Dr. MGM Medical University in 2001, Diploma in Anesthesiology from the Tamil Nadu Dr. MGM Medical University in 2006, and Fellow of the Faculty of Anesthetists of the Royal College of Surgeons from the College of Anesthetists in 2014. He is heading the Department of Multidisciplinary Intensive Care in MGM Healthcare, Amjikare. His experience includes structured training in several teaching hospitals in Ireland, Australia, and in the United Kingdom. His expertise lies in adult intensive care, non-cardiac anesthesia, extracorporeal membrane oxygenation, regional anesthesia, perioperative care of patients before, during, and after the surgery. Under his credit, there are numerous national and international publications, and he is actively invited as a guest speaker in scientific meetings, CMEs, worldwide conferences to talk about non-cardiac anesthesia. Dr. Sabanayagam is a member of the Indian Society of Critical Care Medicine, European Society of Anesthetists, Indian Society of Anesthesiologists. Now I request Dr. Sabanayagam Vaidiyanathan to come on to the stage.
To all the organizers for giving me this opportunity, and I'm sure everyone is hungry by now. I hope I don't hold you all here for quite long. And this is my topic of interest, transition care. Basically, I'm an anesthetist by profession. Then my special interest is intensive care, so I trained in intensive care as well. So this is a picture of a critically ill patient, and this is the place where we work. We try hard, get our patients better, and then we send them to the ward, and ward physicians take care of them. And there is, during the stay of the patients in the intensive care and in the ward, there is an army of people who take care of these patients to get them better. Doctors, nurses, rehab physicians, physiotherapists, and nutritionists, dietitians, and then pharmacists. There is so many people who get them better, and finally we get them to home. So unfortunately, in the developing countries, the setup is such that these patients go from an area where there is so much of care, so much of attention, so many people taking care of them, and then one fine day they get discharged, and at home they're just taken care of with their near and dear ones, and a lot of times they hardly have any clue of what is going on in the hospital and what has to be continued. So I think this is the weakest link, and I am overtly concerned about this link, because when these patients, after so much of pain and effort by a battalion of healthcare people, they go to the ward, they get sick, and I'm worried they'll end up with me again. They'll come back to the intensive care. So, and as a result, I think discharge process is the most important process which can actually change the outcome of these patients even after they go home. It's a complex process. Yes, there are so many things which is involved in deciding when a patient has to be discharged and also where the patient has to be discharged. But if not done properly, it can lead to readmissions. Now this adds on to the cost. At least in the Western world, a lot of countries, the healthcare is taken care of by the government, or it's taken care of by the insurance. But unfortunately, very small proportion of our people are insured, and as a result, it directly adds on to the cost of the patient and the family. So as measures of preventing avoidable readmissions, we have to improve the quality of care for those patients who get discharged and reach home. And then it also helps with the financial well-being of the people. So the objectives for the next 15 or 20 minutes, let me try and finish it off in that time, is to overview and have a look at the discharge process that is currently going on, the effectiveness of various approaches. There are various models which takes care of patients after they get discharged to the home, and then how do you determine the appropriate site of care for these patients who get discharged to home, and then what are the interventions which can reduce the likelihood of unplanned readmissions, and what are the interventions which can reduce the adverse effects for these patients after they get discharged home. Now, the question is appropriateness of discharge. When can a patient get discharged? It all depends on why the patient was hospitalized in the first place. most of the times it's sort of an acute care problem. Either the patient comes for a diagnostic modality or a therapeutic intervention, or they come for a close monitoring. Now, has the problem settled? There are two important things which happens at this point. Patients, sometimes they end up being hospitalized for a prolonged period of time, and these can happen for multiple reasons, not only because of lack of expertise of doctors or nurses on deciding when to get discharged. It's more about where will this patient get discharged. Now that's one important question, because in our setup, we don't have too many layers of setups where the patient can be discharged. Like for example, we don't have too many rehabilitation centers where it's so easy for the acute care hospitals to send them to rehab centers. We only have predominantly two options: acute care hospitals and home. So for this reason, there are many occasions where hospitalization is prolonged. Patients are kept in the hospital for more than the actual time that needs to be. Or at times, because of other social and financial reasons, patients are discharged prematurely. And when this happens, they end up going to the ward, they are not fully treated, and they end up contributing to hospital readmission. So at the time of discharge, there are four important domains which needs to be considered. The most important domain is the medical issues. Will the patient require any further medical attention or surgical attention, like wound dressing or maybe removal of sutures? Is there any clinical condition which can potentially make the patient unstable? That's the first domain, when you want to decide where this patient has to go. Now the second domain is the mental status, emotions of the patient. Can the patient and the family cope with what is happening with the patient? Is the patient depressed? Is there any cognitive impairment? So that's the next domain. Then the physical functioning of the patient. So a lot of times when we, again, this meeting, we were all talking about geriatrics and palliative care. So technically we are talking about patients who are extremely unwell. So these are patients who are physically challenged in many ways. They are not ready to continue their routine life the moment they go to home. So as a result, there will be a significant decline in the physical functioning. So is there a need for rehabilitation? Is there a significant scope for physiotherapy and stuff where the patient can rebuild and go back to their original life over a period of weeks or months? Now that's the third domain we need to think about. And the fourth domain is the psychosocial component, wherein is the patient going towards end-of-life care for whatever reason. So these are the four important domains which we need to consider when we want to decide where we want to discharge this patient. So technically, 75% of the patients will be ready to be discharged home. Now this stats is from a Western study, it's not from an Indian study. 75% technically can be ready to go home. Around 25% of the patients, for various reasons, which can belong to one of those four domains, might not be fully ready to go home. Now these are those patients who are not ready to go home, they have to be transferred to some other facility, a lesser facility, something like a rehab facility or a transition center. Basically a center which can actually bridge the gap between a hospital and home. Now this is something which I borrowed from the Western world. So this is from the United States, wherein they have different hospital facilities ranging from acute care hospitals like what we have to extended care facilities. Yes, we do have extended care facilities here. Dr. Raju gave us a beautiful idea of how the palliative care centers work, but then it's still not adequate enough. As Karthik said, probably in the next 10 years or so, we're going to be double or triple of our geriatric population who would require extended care supports, and definitely we are not adequately staffed, or we do not have the adequate infrastructure to deal with this sort of population. So as a result, we do not have the entire spectrum of care facilities which comes over here. This is typically borrowed from an American journal, wherein the acute care hospitals are the standard of care which deals with patients who have life-threatening problems or who undergo surgeries or interventions and all that. The next level of care, or a lesser level of care, is patients who actually have an inpatient rehabilitation facility, which is a long-term acute care center, or LTACs. That's the next column over there. And then comes the hospital-based transition care units. The next level is community-based centers where there are trained nurses taking care of these patients. And then the last level of care is the extended care facilities. So technically there is a spectrum of hospital care facilities which can take care of these patients. And the Western world, they have the liberty to decide which category of hospital their patients will fit in, and they will be able to put them in that particular setup. But unfortunately in our setup, we do not have that luxury. But luckily we do have centers like that coming up now, and it is very important that we decide whether our patient can go home or should be put in a facility of that sort where they get more nursing care, they get more opportunity for rehabilitation, wherein the patient and the attenders learn and understand the protracted period of recovery that they are going through and the treatment that they have to go through even after going home. Then the elements of discharges, it's not something which is not as simple as we think. A lot of times it's like packing for a journey. The patient would have stayed with us for multiple days. They would have had weeks of ICU. They would have had weeks of hospitalization. And when they go home, there is so many things that would have changed. Just to give you an example, my mother-in-law got admitted with a hip fracture. She is a hypertensive for 20 years and she is a retired nurse. She knows each and every single tablet that she takes, and she's been taking that for decades now. So she knows, including the doses and all that. So she got admitted. She hardly stayed in the hospital for around 10 days. She had a minor complication, so it was 10 days. At that point, the blood pressure fluctuations were there, and as a result, all her medications were changed. And at the time of discharge, she was sent home, and this time with a completely new set of medications. And when she went home, she was not aware of the medications that she was taking. She was not aware of the doses. Almost some 60–70% of the medications were totally new. So she did not know what she was taking. And she ended up taking the wrong medications in the wrong time, and then she went in for a hypertensive emergency, and then she ended up getting hospitalized again. Now she is a retired nurse who is aware of the medications. Yes, of course there are doctors in the family, but one small problem is that she was not educated on the medications that she needs to be taken, and the family was not fully aware. So I'm just trying to give you an example. So likewise, there are many steps when a discharge process happens. One of it is medication reconciliation, just to ensure that all these medications are given at the right dose, in the right prescription, for the right period of time, and then a follow-up has been arranged. And a proper discharge summary which enumerates what the patient went through in the hospital, and then which also tells so that everything in detail, so that wherever the patient goes and ends up in case into a problem or so, people who go through that summary will be able to understand what the patient, what happened to the patient. And then a comprehensive set of patient instructions, and then teach back. A lot of hospitals have this practice. They actually explain the patient. The nurse or the doctor sits and explain the patient what are the list of medications that they have to take, and ask the patient to repeat so that they understand that the patient has got it well. And then a discharge checklist. No, this is just an idea of what an ideal discharge process or a plan should have. So my topic of interest is to try and prevent readmission. Readmission is very closely associated with the length of stay. There are many studies done on that. I've just quoted a couple of studies over here. The longer the length of stay in the hospital, the higher the risk of readmission. Now this is not directly attributable to the length of stay. The length of stay again could have been to the fact that the patient was sicker. As a result, there is readmission. There might have been some complication. As a result, there is readmission. So there are many things which are involved with the length of stay. So the shorter the stay in the hospital, the lesser the risk of readmission. So basically, there are many models looking at how to reduce the risk of readmissions. And those countries which are predominantly dependent on patients' insurance, these are countries which put lots of pressure in the healthcare system, because the longer the patient stays in the hospital, the higher is the amount the insurance has to pay, right? So as a result, they put a phenomenal pressure on the healthcare system, and when there are readmissions, they are pressurized again. So in the US, the government passed a legislation wherein the hospital readmission and reduction program was launched, and there were huge penalties which were levied on the hospitals where the readmission rates were higher. And the hospitals started revamping their discharge process. They made lots of changes. All this happened in the last 2 decades. Within a period of 5 years, in the US, it was found that the readmission rates came down from 21.5% to 17.8%. Now that, we are talking about some 3 or 4% difference, but that makes a difference in probably billions for the healthcare system, and thereby billions of money saved. And they also looked at the causes of readmission, and they found that 27% of the causes for readmissions were preventable causes. So to understand the causes of readmission, we need to understand what are the different factors which might actually contribute to readmission. Now, some of the important factors, sorry, it's a slide, it's a picture actually, so I understand that nobody will be able to see this, the finer print. I'll be able to read it for you. So technically, it all starts with complications of care. The patient might have had a severe condition, whatever it is, there might have been some complications during the intervention plan. So as a result, they go home and then come back with some sort of a complication. That's one important factor which decides readmission. Then there are hospital factors. So there are many times when certain things get missed out. Simple things like a medication reconciliation when it's not done. The example that I gave, wherein the patients are not educated properly. So that is one reason. Then there are patient factors. It might be an elderly patient, multiple comorbidities, and as a result, patient came with a different problem, went home, and then come back to you for readmission with a completely different organ problem. There are social factors again, patient's family might be located too far, so they're not able to come for follow-up, and as a result, they ended up in some complication and they get readmitted either in the same hospital or a different hospital. Then there are community factors wherein proper rehab facilities, physiotherapists or nutritionists are not available to actually take the patient through the recovery process. And then the healthcare system process, access to certain things like ambulatory care or access to emergency care, these might not be available. So these are the various factors in a broad view which can contribute to readmission. And of these categories, some of the most commonly listed problems which can potentially lead to readmission are, one is premature discharge, which can happen in our healthcare system because a lot of patients, especially when they're treated in private hospitals, can go through financial problems. So that's one reason. Inadequate post-discharge support, as in follow-up, making regular phone calls to try and understand whether the patient is progressing well at home, and therapeutic errors, drugs being prescribed wrongly, and adverse drug reactions which can cause readmissions again, and failed handoffs, which again happened in the example that I quoted, wherein the patient did not understand what the list of medications that they have to go through. Then complications, and then other infections which the patient can have in the post-discharge period, and pressure ulcers and falls because of inherent condition and all that. So these are some of the problems which can contribute to readmission. And there are also certain scoring systems which gives you an idea which are the patients who can potentially have readmissions. Now these scoring systems, I'm not going to go into the details, they look at those 4 domains: the medical problems or social problems, domain 1. They look at the psychosocial element. They look at the financial aspect, and they also look at whether the patient has any long-term or end-of-life care problems. And based on this, these scoring systems give you a rough idea. They're not like accurate, but they can help you in deciding who are those high-risk patients who can potentially have a readmission problems. So these are things which we have discussed already. These are certain interventions that we can do to reduce readmissions. One is educating the patient. Second thing is making regular telephone calls. It doesn't have to be a doctor. It can be a nurse, or it can be a trained physician assistant, or even a technician who knows what are the right questions to be asked for each and every particular patient. Some hospitals have this policy of home visits, and with the advent of science, there is telemonitoring. There is a lot of patients whom we have sent home on telemonitoring. After COVID, there is so much of research being done into it where you don't have to get into that infected area, you can monitor the patients from outside. So this can be extrapolated to home telemonitoring as well. And then having a close vigilance on the medication management of your patients who've been discharged. And then putting all this together, multiple interventions, doing everything together with a multifaceted approach. There are a couple of systems which helps with this multifaceted approach. One of this is safety net hospitals. So this system has a multidisciplinary team which deals with the discharge plan. Any patient so this is a set of hospitals which is which are grooming themselves to become safe hospitals, wherein these patients who get discharged from their hospitals, they will be very closely followed by a multidisciplinary team. And this multidisciplinary team will have doctors, nurses, physiotherapists, rehab physicians, dietitians, everybody. And they have their own plan charted out. And each and every patient who get discharged from this safety net hospitals will be followed up by this multidisciplinary team in a regular follow-up pattern. Now that's one of the approach. Then the other approach is having transition care partners. And there has been enough research put into this. There is quite a strong evidence to suggest that when we put through the patients through any of these mechanisms, either safety net hospitals or the transition care partners, the risk of readmission has found to be low. The risk of adverse outcomes for these patients, either at home or at hospital, has been found to be low. And they've also noticed that it also adds on to decreasing the cost. In the Western world, it's for either the insurance or the government. Here, it is directly for the patient. Some of the transition care models which have been tried out in the US is there is one care transition intervention. The strategies that they use is what we have discussed before. One is patient engagement. They educate the patient and the family intensively, and they make them understand what they're going through, number one. And they maintain an individualized patient record. They have a dedicated transition provider. So basically they identify one person who helps the patient with the transition, who acts as a liaison person between the doctor and the family, and they are in regular touch with the family to try and ensure that the patient is progressing as planned. And then these are the people who actually facilitate communication between the patient and the doctor. And then there is an outreach team, and a medication reconciliation is being done on a regular basis. So the care transition intervention and transition care model are the first two plans which were actually successfully done in the US, and they have proven to decrease the readmissions, to decrease the adverse outcomes. There are also a couple of other projects which were introduced at a later stage, which is Project Red and Project Boost. These are also transition care models, and they used almost similar strategies, and they also found to be equally effective. All these care models, they basically look at three different things, which are pre-discharge interventions. They very closely monitor and have an idea of what are all the interventions and things that were done for the patient at the time or before the discharge. And then the post-discharge interventions which are required for this patient even after the patient goes home or to a transition care center. And then they look at the bridging interventions, those things which were done at the hospital and which has to be continued further either at home or in the transition care center. So they qualified those interventions into three, and these three areas were looked at very closely. So the ideal transition care center or a bridging center has strategies in plan which decreases readmissions and which decreases the adverse outcomes of the patient. And there is always a transition person or a clinical lead person for each and every patient who closely monitors the patient wherever the patient is and acts as a liaison person between the hospital and the team of doctors or the healthcare people who are treating the patient. And to establish a system like this, it's expensive and it requires a lot of resources, but then it's been found to be quite effective. What is lacking even in the Western world is that the exact cost for implementation and how effective it is in actually decreasing the cost of treatment of this patient by preventing readmission, what is the cost actually saved? So that is not exactly translated. No, that is something which is lagging, and definitely will be useful for us to understand how much productive it is from the cost front. So as a final slide, an ideal transition center or a bridging care center should suit the physical and mental needs of the patient and the family. And quite often, or almost always, we have patients by the time of discharge, they are craving to go back home. But a lot of times they are not ready to go home. Here you are, as a doctor, you really want the patient to go home, but then you know that the patient is not fit enough to go home. So transition care centers would be a best balance for these sort of patients. They are leaving the hospital, they are going to an almost home setup, but at the same time, they have all the facilities which helps them with a speedy recovery. That is continuation of care at the time of discharge as you want it. And then availability of specialists, availability of doctors, nurses, and all the other support care systems that the patient would require. And then the scope for escalation of care if in case it's required. Thank you.